And as a consequence that there was not a lot known, a lot of my articles were actually really difficult to publish because people said, no, there's nothing in Down, so don't worry about that. But I think it would be interesting to tell you, as parents and as carers, something about the immune things that can or cannot happen in Down syndrome and why it's quite unique in Down syndrome and why I think uh, the parents, the carers, but also the healthcare professionals should be aware of the things that can happen because then you can also act on it. So um, let's have a look. Hopefully I can also, yeah. So Down syndrome is the most common syndrome in human beings. So everyone should have a knowledge about Down syndrome. Everyone should be able to recognize a child with Down syndrome, but should also be aware about the specific conditions in Down syndrome. So most commonly, it's caused by an extra chromosome on 21 or a critical region in chromosome 21. Depends on which country, like how frequent the live births are, but it's the most common syndrome in any part of the world. And as we all know, we have specific facial features, but also a different level of mental and motor developmental things, and also congenital malformation. So for instance, in 40%, around 40%, we see heart defects, and sometimes you also require surgical intervention, but not in all children this is the case, which I think is very fascinating. And if you look at the life expectancy in sort of the last 50 years in Down syndrome, this has massively improved. And this is mainly because of the improved healthcare in heart conditions. So the first years of life, if you need to undergo a heart surgery for one of the heart conditions in Down syndrome, the heart surgeries have improved so massively that it's very close to 100% actually. So that is really, really helpful for our community with Down. And that is also why also doctors who take care of adults with Down syndrome should be aware of specific issues that can happen in Down syndrome because children become adults and then adults 60, 65 is currently sort of the life expectancy, but I think it will improve furthermore if we sort of get on top of it with the healthcare. Then if we go super, super specialist, so the immune system is basically your defense against viruses and bacteria, or it is a matter of balance so that you're not, for instance, attacking parts of yourself, or if you have an infection, that you also stop in time. So if the infection is gone, then the immune system needs to calm down and just, be there in case there's a new infection. And if you look at Down syndrome in the whole community, it doesn't really have to happen in your child at all, then there is a combination where there might be less specific immune cells of a specific sort, or there might be a balance issue. And together, this can lead to specific issues, and I will go through the several things that might or might not occur in children with Down syndrome. So you can have specific infections or more infections. You can have specific issues with inflammation, and inflammation means it doesn't have to be that there is a specific virus or bacteria. It might just be that your immune system is going a bit over the top, and is actually should not do that. There's no reason why it should do that. It can also be that you have autoimmunity, and autoimmunity means I'm attacking something in my own body, which I should not be doing because that's part of my own body. And then there is also a bit of malignancy, which I will address, although there's also some positive about malignancy because specific malignancies are more prevalent, but some others are actually less prevalent in children with Down syndrome. So if you look at the clinical features, we made an overview article a couple of years ago because actually it was not a lot out there about the immune system. And if you look at infections, and I also use some articles and some background information from different parts across the world, but overall, we can see that both in children and in adults, infections can be an issue. And it's mainly of the chest and the upper airways. And in children, you can see that they have more frequent upper airway infections and also more frequent like bronchiolitis or chest infections. If they go to hospital, the doctor should be aware that the child might stay longer in hospital than a child without Down syndrome. And that's not a problem. We can do that. But this is sometimes twice as long for the same infection as a child without Down syndrome. Then there can be also an increased risk of damage to the lungs. So also doctors need to be aware that sometimes you need longer antibiotics and have a bit more patience for the child to have time to recover from an infection before you send them home. If you look at adults, but actually this is already the case in children, often what I see in my clinic, that in the first years of life, you have, more heart surgery, you have more other reasons why you could also have more infections. But overall, when the child is sort of 6, 7, 8, they have far less infections moving forward. So if you're basically past that point, 6, 7, 8, then you will see, if you talk to the parents and if you see the children, that a lot of them have far less frequent infections, and they will have the occasional infection, and we have to give occasional some extra antibiotics, but overall they're much better than in the first years of life. So we have to also be aware that even if in adults we have less frequency of infections, actually already in children we see this happening quite quickly after you're sort of going 6, 7, when you're sort of attending school. So you're exposed to all kinds of bugs at school, especially in the winter season. But still then, the children are already doing much better. Overall, if you look at all the data that is out there in the world, infections are really important in Down syndrome. And people need to have, like lifelong, they have to be aware that in Down syndrome, you might need a lower threshold for antibiotics or a little bit longer antibiotics than in people without Down syndrome. Then if you look at specific the respiratory tract infections, so we have bacterial infections, we have viral infections, fungal infections, not so much a problem. Bacterial infections are definitely increased, but also often secondary. So for instance, you have a viral infection and then it's tipped over with an additional bacterial infection. So even if you're admitted to the hospital and they say, we have found an RSV or we have found a specific viral infection, that's fine. But maybe we're not done. So if you're in the hospital with your child and you think, okay, we have found the RSV, now we just need to recover, but then you see a change in your child, make the doctors aware and say, wait, is there a secondary bacterial infection? Do I need an extra antibiotic course for my child at this stage? Because there is like a change during the admission. For viruses, there is quite a lot of data for three specific viruses, and that's just because that's how they have collected the data. There's no really a systematic prospective good study where they just have said, let's just look at all the children with Down syndrome, let's collect all the data for viruses. So the main viruses that people have zoomed in the last sort of 20, 30 years are RSV. This is the one that causes the bronchiolitis early in life. And sometimes you need to go to the hospital. Sometimes you need like support with for your breathing, a little bit of positive pressure or oxygen. And in some cases, you even need intubation and ventilation. And then you end up on an ICU. This doesn't have to happen, but this can happen. Then we had, of course, this swine flu already a few years back. This was a pandemic. We thought then, was the biggest pandemic. Since then, of course, we have the COVID pandemic. And also in the flu, you can see that they have more requirements that they have to go to hospital or that they need, for instance, an antiviral to recover from a flu infection, which also sits with the advice that flu vaccination might be helpful in people with Down syndrome. And then, of course, we had the big COVID pandemic, which was quite interesting to see how are the children and the adults with Down syndrome going to respond to this completely new virus. So RSV is really an important one. And my colleagues in the Netherlands, but also in Canada, they have done some investigations. And even if you don't have a heart condition or a chronic lung disease, independent of this, Down syndrome is actually increased risk factor to have more severe RSV than in children without Down syndrome. So we have to be aware of this. In some countries, you will get palivizumab, like this protective antibodies standard, as if you have Down syndrome in the first or sometimes even the second year of life, even if you don't have chronic lung disease or if you don't have like a heart condition. In the UK, it's slightly different. It sits sort of with these risk factors. And of course, I don't know if you know this, but there was a new vaccine that popped up last season, which is this nirsevimab, which is quite interesting, but it was not really available in the last season. So we, of course, keep our eyes out, especially also for the Down syndrome community, if this will be available from this year in October, because that would be one shot instead of 6 injections, which you need for the palivizumab. So let's see what's happening later in the year.
Okay.
So I think someone asked a question. Maybe not. Okay. You can ask also questions later because I will do the presentation. Of course, you can interrupt me to ask a question, but also because we're recording this, you can also ask the question later if you want to also talk about your child personally, which I would love if you would switch your camera on later. Then we can also discuss about the different things. So this RSV is important for children with Down syndrome. So what I would like to know later, maybe at the end of the presentation, is how do you feel? Do you have access to healthcare in your area when it comes to infections? How is like the counseling and the advice and the support that you get in your area in the UK? My experience is it can be quite patchy where you are, how you feel you are supported, and what is the information that is available, but also when you go to an emergency department, how seriously you are taken and how you can advocate for your child. Sometimes your child is nonverbal because of the age, but sometimes your child is also nonverbal because of Down syndrome or has a learning disability. And then you feel strongly as a parent, and also I think as a doctor, that we need to advocate. So how do you feel this is happening in your area? I would like to know. What's really important in Down syndrome, that actually the immune system is just really, really, really small element. I often get referrals and they say it's all the immune system. Please investigate the immune system. It should be all the immune system. And then often this is not the case. It's actually not the immune system at all. And the immune system, when I test it, is quite okay. And then we have to look at all the other different factors that are important when you are trying to avoid respiratory tract infections. And if you look at a child with Down syndrome, this was a picture we already used 10 years ago, just to highlight that people should not just zoom in on one part of the child, but you should have a holistic view. At any child, it has nothing to do actually with Down. For any child, you have to look at all the different elements that come together, and you might have to treat something else to avoid a respiratory tract infection. For instance, if a child has a lot of reflux that comes from your stomach and goes up, this acid or these fluids, and then it goes into your chest, yeah, of course you will have a higher risk for infections or inflammation in your chest. It has nothing to do with the immune system. We should treat the reflux and try to avoid fluids going into your airway, because there should be no fluids in your airway. For instance, we also see, of course, that you can have a heart defect, but you also see a higher pulmonary hypertension, so a higher blood pressure in your blood vessels in your chest, which can also contribute to more infections and is not per se anything to do with the immune system. Overweight, to have like a healthy weight and to be exercising is important, especially teenagers and adults and young adults, children and adults with Down syndrome. And it's only a really, really small part actually is the immune system. I appreciate I'm a specialist, but it's maybe 10% of the whole story when it comes to infections for children. So the COVID, of course, was very interesting. And what we saw is that they actually were more unwell with COVID. Not all of the children. Some children were perfectly fine. Everyone else in the household was unwell, and they were just like sailing through it, and there was no issue at all. So we were telling the parents, oh, you could have more severe COVID. And they were, well, we had it, and nothing happened. So yeah, there you go. This is the reality of Down syndrome, that it's never predictable and you just have to see how it goes. But some of the children we did see on our ICU in Great Ormond Street when we had the COVID pandemic, I said to them, okay, give them a little bit longer the steroid to dampen down actually the immune response. And then you will see if you give the child a little bit more time, they will come out of it okay. And that also did happen. So the children that had a bit more severe course, in the end, they were fine. It was more the adults with Down syndrome. And that also sits, I think, with sometimes if they are more isolated and no one is telling them you should go to the hospital, because what is your support network in the middle of a pandemic, in the middle of a lockdown? That also went hand in hand, that they were not just more severely unwell, but some of them actually passed away. Adults, not children. The children, they came out of it okay in the ones we saw. So that's also reassuring. And then, of course, there were like publications in the middle of the COVID pandemic. Everyone could just publish anything without any review of other scientists or doctors, because we didn't have time. We had to just move along. But there were some very good experts in the United States, and they have a really good setup of lab and research. And thankfully, because I couldn't prove it, but I already had the suspicion, one of them said, be aware they could have a bit more inflammation when they have corona, when they have this COVID, and maybe you should think about this. And this is what we did. So we responded to these publications that came out. Also, they could have more bacterial infection secondary to the viral infection. So they also had a lower threshold to be treated with antibiotics. What was important, I think, in the Down syndrome group in the adults is that, of course, there's an increased Alzheimer's disease, sort of 50, 60 years of age, more people have Alzheimer's disease. So also that's what I mean with you need a network around you to also make you aware you're not feeling well, you should go to the hospital. And that, I think, also had a massive impact during the lockdown for a lot of people across the world with Down syndrome. So I want to highlight these things from your own website, because I think they're very cool posters. And also, and maybe we should do another round on the A&Es to hang them there, because sometimes you're really dismissed. You go to an A&E and they say, hey, it looks perfectly fine. And that's true, because children with Down, they always are, quite perky, they're quite sassy, and they will be fine until they're not, because, that's how they sort of behave. They're not going to make a drama unless there is a drama. So I think the people should really listen to the parents. If the parents say, no, it's really off, it's really different from, whatever it is that you normally do, what your normal baseline is, then we really should investigate. And if needed, make an X-ray, do some sputum, start some antibiotics. Just listen to the parents, because, they know. And then I was just wondering, like, how is this for you? I don't know how old your children are, but did you have a child or an adult, with Down syndrome during the COVID pandemic? And how was your experience? Were you worried or not? Did you have a COVID infection? And how did your child or the adult respond to it? I'm just curious to know, because a lot of this is, of course, not published. And also, did they give you any treatments, any steroids, any antivirals? Did you end up in the hospital, or were you actually pretty okay at home? So then for malignancies, I'm not a malignant expert, but I will only give you a little brief overview. And I think what's important to know, this element, malignancy, this is what doctors do know a lot about, in the sense that people do have an awareness that in the first few years of life, there is a slight increased risk of specific hematological malignancies. So once you're born, sometimes we see this white blood cells that they are elevated, and this is transient. This is a specific condition, transient myeloproliferative disorder. This is actually benign, and it might go away, and only very, very rarely, and I see this very, very rarely in my clinic, it will develop into something called AML. Most cases, it doesn't develop at all into AML. we have higher frequency of ALL early in life, and it's only the first couple of years of life. And after that, that peak is completely gone. So if your child is, for instance, 8, you're past that peak, essentially. What is good to know that some malignancies, some tumors are actually decreased if you look at the population risk. So you actually have less risk than people without Down syndrome for some malignancies. So overall, despite, this peak early in life, your overall risk for malignancies actually lower in Down syndrome. And this is something I think people actually don't know. So I also I wonder if there are any people on the call, if you want to say something about this. I appreciate if you don't, to say something. If your child had a malignancy, how was the diagnosis made? Was the treatment different? Were the side effects slightly different? But, if that's not something that you would like to discuss, I appreciate that. Then autoimmunity. So this is where you are attacking part of yourself, which you should not be doing. So here, again, there's a lot of data in the world, but most of the data is actually sort of white Caucasian data. So it's far more European data. So I'm not sure if this goes for every child in the world, like African, South American. I don't know for sure. Most of the data actually comes from a lot of my colleagues from Europe. But overall, we see that there is more thyroid problems. So this is also why often in the screening programs, you have like a yearly screening for your thyroid function. Sometimes it's that you actually need thyroid hormone. Sometimes it's just more that it's a bit overstimulated, the thyroid stimulating hormone, but that your overall thyroid hormone is actually still in the normal range. But if your child is sort of tired and you think like, I'm not sure, this is something, of course, that we should test, the thyroid, because that's sort of your metabolism. It keeps you it's sort of a driver. But this should be actually standard of care in the area where you are and the pediatrician that is following you up. Celiac disease, there is an increase theoretically, but in practice, I actually don't see a lot of children who need a gluten-free diet. And I think it's because we have a bit of bias in the data and how it's collected in the last sort of 40 years. But it's there to test, and it sits also in the screening programs. Then there is a little bit of increase in diabetes, the type 1 diabetes, not the type 2 per se. And also we can screen for this, but this also comes with symptoms. So you will recognize this if this happens. I don't see it that often, but in theory, you have a slight increase in diabetes. So here also, of course, I would like to know across the areas in the UK, are you screened for these type of conditions? Do you feel, you have sufficient screening for this? Did they find anything? Are you on thyroid hormone or not? So I would wonder like how this is across the UK as well. Then inflammation. So this means like your immune system is going a little bit over the top. Should not do this, should be in balance. So here we have specific conditions, and I would like to highlight some because some of them I think are really, really interesting in the context of Down and often dismissed, and it should not be the case. So the first one is if you have joint inflammation, and joint inflammation in the context of Down can be actually a specific entity, Down syndrome arthritis. And why I'm emphasizing this, if you look across rheumatologists, they often will give you a one-size-fits-all treatment. And sometimes the toxicity, the side effects in Down syndrome are different, and you should treat it slightly different. You need to have a rheumatologist with sufficient experience to appreciate that Down syndrome, although in the sort of overall how it's like sort of set up, like arthritis, different forms, GIA, all these different systemic sort of arthritis, they are not differentiating separately in all the publications Down, also because they felt maybe then the selection bias is actually not favorable. We have not enough data and we're not giving you the right treatment, but the rheumatologist should be aware of this. And if they are not aware of this, you should really ask yourself, do I need a second opinion or extra input from a rheumatologist? Because the side effects can be different and the treatment choices can be slightly different. You need expert input for it says internet. Yeah. So hematology, you can have a slight over and that your immune system is sort of attacking your own cells. This is super, super rare. I only see this because I'm an immunologist. I think most of the people who work with children with Down never see this in their career. So I'm highlighting this, but also be mindful that I'm tertiary immunologist. So I get these referrals from half of the UK. So I will see, the extreme ends. This does happen and it's sometimes hard to treat. So yeah, they need to come early to me if possible. Then dermatology, I think is really, really interesting. You can have some hair loss. You can have all kinds of skin flares. Sometimes you have this sort of that your child has a bit of this blossoming, this marmoring sort of skin, which sometimes can be just the baseline. And then if you come to an A&E and they say, "Oh, is this a sepsis?" And then you say, "No, this is the skin color and how the skin is normally in my child." But this can fool basically the doctors in thinking, it must be a sepsis. Let's just start on antibiotics. And then 2 days later, you realize, no, this is the normal skin. So yeah, we should have listened to the parents. But what is really important is the hidradenitis suppurativa. And this hidradenitis, we almost want you to write it down because there's so many children that get a referral to me because they have recurrent boils. So they have recurrent boils in their groin area or in, under the axilla. These are young teenagers or young adults. It's very painful. It's recurrent. They sometimes start to walk like this, sort of, and then it's very painful. And they have often a high threshold for pain. So if they are in pain, it must be really painful. And then often they are treated in the local hospitals with recurrent antibiotics. Sometimes you have to decolonize. It must be a bacterial infection with staphylococcus. Actually, there is a specific condition, this hidradenitis suppurativa, which is also there in the general population. It's just way more higher in Down syndrome, and it also starts earlier than the sort of young adult age. It already can start in the teenager age. Maybe it's with hormones, maybe it's with growth. We don't really understand why it's that more prevalent. But what's more difficult that they have, for instance, standard regimes that they say, do this antibiotic course for the next 3 months or 6 months. Well, a lot of my children are not having that. They're not liking the texture. They don't like the taste. They are not going to, do 3 to 6 months of antibiotics every day. So you have to be a bit more creative. There is a special hidradenitis suppurativa clinic actually in one of the London hospitals. So I'm also referring more children specifically to this clinic, and also it's an adult clinic. So you can also actually refer adults to this clinic. Not super sure if they're happy that I'm referring so many people to their clinic, but I think it's right because they have a more prevalence of this hidradenitis, and we have to see if they go through the standard protocol, if the standard protocol is actually right, or if we should do something else. And what we might be doing else is this specific medication, which is called a JAK inhibitor. And the JAK inhibitor can manipulate a bit the over response of the immune system, which can happen in Down. And specifically for hidradenitis, there are a lot of clinical trials with very small groups of patients across the world that have been started, but I couldn't find anyone with Down syndrome in those trials. So I'm keeping my eyes out if they publish anything, if they are brave enough to also include people with Down syndrome, because they should, because this is far more prevalent in Down syndrome. So I think it's unfair if we are not putting people with Down syndrome in the trial, because it's less convenient maybe for the people who are running the trial. We're looking into this, if maybe in the future we can also do something like this in the UK. But of course, we are in the NHS, so we have to take probably a little bit more time to set this up. But we're looking into this because I think it is relevant. And I would also like to know if you have seen this in, your child or in a young adult with Down. Then for neurology is also really, really important in Down. So in neurology, we already know, because there's a lot of data out there in neurological conferences, that there is more Alzheimer-like dementia. And this starts earlier, sort of like 50, it also happens if you grow old enough in 3/4 of the adults with Down. So this is really, really something I think we should also keep our eyes out. If there are specific treatments coming up for Alzheimer, can we also get then the people in with Down syndrome in these trials or in these treatments? And maybe we should actually have an earlier treatment specifically. Then there is also this condition. They say it's sort of new, but it's actually not new. It has been out there for many, many years, but maybe we have not looked at it hard enough. And this is called Down syndrome regression disorder. Very, very rare in the Down population. So you don't have to worry that all, children get this. I hardly see it, but if you see it, it's dramatic. It's a day and night difference. People tell you my child is a high performing child with Down syndrome. It was going completely okay. And all of a sudden, it's a completely different child. All of a sudden, it's a completely different child, like in teenager or young adults. And parents can pinpoint it. They can say, look, this is what's happening. He's staring at the ceiling for hours, or now he's a bit sort of aggressive. And this is neuroregression, we think. We're now getting sort of the first children into the clinic because we don't have a set up pathway for this. So what we're trying to do is following what the people have been doing in the United States in the last couple of years in various trials. They have now tried with immunoglobulin, so antibody replacement, but in a higher dose, and also with some other medications like steroids, or again, this JAK inhibitor, or with like sleep medication, other medication. They have tried to reverse this process. And John Santoro, who has been pioneering and is on the forefront of this. We spoke to him a couple of weeks ago because he was actually in Great Ormond Street to do a talk. And then we said, can we use your protocol? Can you give us a little bit more data so that we can copy paste this while we hopefully are getting a trial in the future? But that's probably 2 years away from where we are now. So this is something that if this is happening in your child, we also need to know, because we might be able to help you. So this is for me an important topic, this inflammation. So I would like to know if you have anything like a story or anything in your child or in other children that you know, especially these recurrent boils. I think is interesting because you might be just recurrent boils and you don't know it's hidradenitis, this neuroregression, or this Alzheimer. Then immunophenotype. This is a bit more technical, but I will try to make it a bit more, hopefully, simpler than the slides. But this means like, how is your immune system built up? Like how many of the cells, how are they working together? So this is, of course, a bit my specialty. So what we have in the UK since a couple of years is this pilot called newborn screening for severe combined immunodeficiency. This is already in place in the United States for many, many years, and across Europe also has been there in place in the different countries also for many years. But we had a bit of a delay also with COVID because we were about to start and then we had COVID. But what we are trying to do in newborn babies is trying to diagnose the severe combined immunodeficiency so that we can make sure that they don't catch any infection so that we can actually give them a treatment to prevent for them to become really unwell. What we also have seen is that some of the children with other conditions are picked up in this newborn screening, not because they have this severe combined immunodeficiency, but because they have all kinds of different other conditions. And this can also happen in Down if you're not diagnosed already prenatally or after your child is born. Sometimes you get a pickup through this newborn screening. And what we did in the past is we looked already many, many years ago, but it has been also confirmed in different other studies. And I was in Germany last weekend, and also there they saw it in their newborn screening. So basically what you see, we measure these tracks. This is a measurement for your immune cells, specific immune cells, T cell immune cells, and T cells are important to fight off viral infections. And when we looked at the gut records, this was in the Netherlands, and we just got them all out of the storage, and then we put this test on way before we had any newborn screening for this condition. We just wanted to see how are our downers doing in comparison with other children who don't have Down syndrome. And then here you have this blue circle. The blue circle are the children with Down, and this orange, is it orange? Yeah, I think so, are the healthy controls. And actually you can see overall, you don't have to be an expert, that they are producing less of this TREX. So this is a measurement. So they have less T cells, but these are sort of the cutoffs for severe combined immunodeficiency. They're not going that low. They are lower, but they're hardly going to that level of severe combined immunodeficiency. And this fits with their clinical picture, because my children with Down, they don't pop up with the type of infections that you see in severe combined immunodeficiency. They don't have, for instance, a high fungal infections or specific other infections. So even though they have lower numbers, it doesn't mean I have to immediately jump on them. It's just something that can be picked up in the newborn screening. If your child has not already been diagnosed with Down syndrome, they might actually diagnose you in that way. Then these are like very old pictures from my PhD, so this is like, sorry for this. But basically what we try to do is very simple. We just tried 20 years ago that if children came into our hospital, we just asked the parents, could we just take a little bit of your blood from your child? And they all said yes. So that's really helpful. And I think that's also typical for the Down syndrome community, that the parents agreed and that they all say, of course, this is helpful, for any other child with Down. Of course, we will help you to get a little bit more information and knowledge. So what we did, very simple, we just looked at their different type of cells. White blood cells, but specifically the cells that are the more clever part of your immune system. The T cells who fight off infections, viral infections, the B cells who produce antibodies against infections, and then you have different types of T cells. Some they are more helping, the T helper cells, and you have this cytotoxic T cells, and the cytotoxic T cells, those are the ones that can attack for viral infections. So what we saw in the beginning, from the very sort of start, they produce less of these cells. And then in the first year of life, when you are born and everything is new for you and you need to make a response, like, who are you? Oh, you're an infection. Okay, let's make a response. They make less response. They copy paste less of their cells in comparison with children without Down syndrome. So they don't have this explosion of copy paste of immune cells. And that's why in the first 2 years of life, their cell counts are lower in comparison to children who don't have Down syndrome. After that, if you measure them, as an adult, for instance, just as a one-off, then they're super close to anyone else. So it's only in the beginning when they should be copy pasting and making a lot of memory cells against, any for the future for any infections. They're not doing it in that way. It's interesting because sometimes I get a phone call and say, look at the low numbers. This is like really, really low. They should be having lots of problems. Then I ask the doctor, but does the child actually have problems? Because sometimes it's just a matter of numbers, and the numbers might be low, but are we looking at numbers or are we doctors? We should be looking at the child. So often what you see is, despite these low numbers, when they're like 6, 7, 8, most of the children are fine. They are, okay, I have these low numbers, doctors. You can look at my numbers. You can repeat these numbers if you like. But anyway, I'm just going to carry on and do my own thing in the meantime, because I'm actually okay and I'm not actually having lots of infections. So the numbers in itself in Down, that's not per se a good measurement. So, people ask sometimes, should we screen everyone for lymphocytes? Well, from a research perspective, that would be interesting. For an immunology doctor like me, that would be interesting, but actually not needed, because it's not going to reassure you, because the numbers in itself is not as important as how the child actually is doing. How many infections? Do you need antibiotics? Do you end up in the hospital? If you don't, then apparently these numbers are fine for your child. And we should not over exaggerate, only like it's a number game. It's not just a number game, it's what you do with it. what's really important, and this is what I have been trying for many, many years in the publications, people say, they just age a bit quicker. Look, they have a bit of Alzheimer. They are a bit weaker in their muscles and they have a bigger tongue. And that's why they get these infections. Don't look at the immune system. It's just there because they age a bit. Uh, sooner, quicker than other people. And I was like, no, 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 this is not true. I'm going to prove it. I'm going to do all these measurements. And it was really difficult to publish because all the other people that had been publishing and they published together and they talk to each other and they agree between them. They said, no, no, it's all precocious aging. But then if you say, look, this baby already has different numbers. Look, the makeup is already different from the start. Then people were like, okay, maybe, you're not already aging when you're just born. So that was interesting to try to and yeah, get that concept out of the literature. Vaccines. So vaccines overall, they actually do really well on vaccines. So it's definitely a benefit. You know, I'm very much in favor in for vaccine
Micah, is everyone struggling to hear her?
perspective to publish because people say, no, we want extreme differences. But sometimes it's not the extreme differences. It's actually, if they're doing fine, it's also an important message because it means that, you know as a parent that your child might profit from vaccines in Down syndrome. What you see is that sometimes they start really okay, but then they drop the responses quicker than some of the other children. And the one that I would like to highlight is the pneumococcal, because a couple of years back, we changed a little bit the pneumococcal vaccine schedule as part of the UK immunization schedule. So instead of having multiple pneumococcal vaccine boosters already in the first year of life, and then, at the sort of 12 months, another booster, you actually dropped one of the vaccines for pneumococcal in the first year of life. Not in every country this was done, but it was done in the UK also to prevent a bit of vaccine sort of, people get a bit of tired, like does my child need so many shots? So you get a bit of hesitancy for vaccines or fatigue. And they said, maybe we don't need that extra shot of pneumococcal. And I think it will be interesting for us in Down syndrome to see, do our children have more pneumococcal vaccines and are pneumococcal infections, and are they pneumococcal vaccine types? Because if they are, then maybe actually they should need an extra shot. So sometimes what we see in the clinic, if children are referred, then we measure tetanus response, we measure the pneumococcal response, and then we say, the pneumococcal is a bit low. But then I also tell parents, well, actually, you only got one shot so far. So actually, that's not actually a bad response. Let's just give an extra shot and then measure the response. And then you will see most children will make an excellent response. And then we sort of say maybe in 3 or 5 years' time, we will repeat the response and see if it drops quicker in your child. If that's the case, we can give you an extra booster. If not, then actually we don't have to give you extra boosters and you can just follow the standard UK immunization schedule. Flu vaccine is something we would recommend. But of course, it also depends on, how you feel about it. And sometimes the flu is a good match for the flu that is out there in the season, but sometimes it's a complete mismatch. And then you have a flu vaccine given in hopefully sort of September, October, but then the flu strain has changed and has like mutated itself. And then it's not the right flu vaccine, and then you're still as much of risk for flu because actually this vaccine is not the right one for the season. So it's always developed a bit sooner, the flu vaccine, because it sort of goes over the world and it mutates itself. This is the clever thing about flu. It can adapt itself. So by the time it comes to us, the flu vaccine has to already been developed ahead of time so that it's ready for the season. But then if the flu is a bit clever and has changed itself, it might not be a match with the vaccine. And that's sometimes why you say, oh, but this winter the flu vaccine was not working. That could be the case if the flu is not the right strain for the vaccine. It doesn't matter. It doesn't mean that, next year you should not give the flu vaccine, because some is exactly like the right flu vaccine, and then actually it might prevent a flu infection in an adult, especially. The
Um,
hepatitis the hepatitis data, I think that's really old school data. Actually, it's more like when all the children were still institutionalized. Actually, don't want to talk about that because I don't think that's where we should be. We should be in the community. They should not be in a special institute. So all that data is sort of from the 60s, 70s. So I'm sort of ignoring that data, if that's okay. Yeah. So here I also
Sorry,
would,
excuse me, Mike. I don't know if you can, it's Nicola.
yeah.
Your internet dropped out at the beginning of that slide.
Ah, okay.
We missed the kind of introduction. It picked up again when you were just starting to talk about the pneumococcal and influenza flu, but
Uh-huh.
the sort of introductions, so the first
Uh-huh. Yeah, I
two
can I
bullet
can
points,
repeat that
if you
because
don't
what I
mind whilst
yeah,
it's
yeah,
there.
and I hope my internet is stable enough. Okay, yeah.
Okay
Just
now.
interrupt me, Nicola, if
Thank you.
because that would be a shame. Because what I was trying to say is that the vaccine responses are actually quite good in down, and that they really profit from vaccinations because they make a good response, but sometimes they drop the response. Did you hear about that the pneumococcal vaccine schedule had changed in the UK? Did you hear that part or not? No? Ah, okay. I will go
Um,
back to that part
no, I
because
don't think. I thought we'd heard quite a lot about pneumococcal, but I don't remember you saying about a schedule. No.
okay, I will go back to that part because I think it's relevant for down. So that's okay. It's fine.
Okay.
The hepatitis, we're not going to discuss the flu. We heard the pneumococcal for me is important because, as I said, a couple of years ago, the immune schedule was adapted in the UK, and that meant you dropped one pneumococcal vaccine in the first year of life out of your vaccine schedule. And that means now, if I see children also without Down syndrome in my clinic already before they got the second shot, sort of at 12 months of age, 14 months, sometimes it's slightly delayed, they might have a low pneumococcal response when you test it in the lab, but actually it's only because you got one shot. You actually didn't get an additional booster. You only got your first shot in. And then instead of getting overly worried and saying, oh, see, you have a problem in your immune system, it's better just to give another shot of pneumococcal, test it again, sort of bare minimum 4 to 6 weeks after you did a repeat vaccination, and then to see how the response is. Because you will see in down, most of them will then actually have made an excellent antibody response to the different pneumococcal serotypes that I can test for. So this is important because, for instance, in other countries, you still have 2 or 3 shots in the first year of life in these combined vaccines that do contain pneumococcal. And pneumococcal is the one that can drop over time the antibody response in some children with Down, not in all at all. So sometimes I'm giving them an extra shot, like 5 years later, 10 years later, just to boost them up, just to give them a bit of sort of an oomph for pneumococcal infections. And then you will see they make an excellent response again. So that one is the one that is slightly different type of vaccine. Yeah. But overall, they really profit from vaccinations. They make really good antibodies. Also, in general, it's very rare for a child to be on antibody replacement. If your child needs antibody replacement in the context of Down, I actually feel you should be seen by an immunologist because this is very, very rare. Normally, they have elevated antibody level IgG, and this is the one we normally replace if they are too low. It's really rare that they are low. This can be maybe in the context of a different treatment, or they actually need more genetic testing for another condition in the immune system, because I hardly see a child that needs antibody replacement. That's really, really odd for Down syndrome. And then I'd rather see them myself, if that's okay. Yeah. So was that okay, Nicola? Could you hear that?
Yes, that was
Yeah.
perfect. Thank you.
Okay, good, because I don't want to miss that part. Okay, so this is what I would like to know. Is your child on any prophylaxis, maybe a bit of azithromycin or not at all? Does it make a difference? Do you feel actually this is a non-topic? I know my child is fine. I never need any extra antibiotics. Or how do you feel about vaccinations? Did your child respond to the vaccinations with, for instance, side effects? Or, you feel like I'm not in favor of this flu vaccine, or what about COVID? What about RSV? So I would like to know how people feel about this. We have been working on a vaccine guideline for Down. Also, one of the parents read through the vaccine guideline, but I think it's still sort of pending for to get out there. And we're also waiting a little bit on what's happening with RSV. I contacted them last week, like, is there any update for this winter? Can I already put something, cheeky in the new vaccine guideline? But I think we're still pending, the higher level advice from the people who are involved in the vaccines and in the palivizumab and nirsevimab. Yeah. So genetics, I'm not going to talk a lot about genetics. You are parents who have children with Down. The only thing I would like to say is that sometimes people are super simplifying the fact that you have extra material, you have extra chromosomal material. So your child is unique. Your child has, your genetic material, and that makes us all unique, right? No one is the same. So, I'm like sort of a product from my parents, right? And then you have a little bit of chromosome 21 extra. But it's really, really interesting because these genes, they are not just like separate, they work together. And also, if you look at different tissues, why do half, sort of 40%, have a heart defect if it's everyone is the same? It's not true, because if only half of them have a heart defect and some of them need a heart surgery, that means that the tissue expression and how it works in, for instance, the heart is apparently different. So it's far more complex than just a little bit of extra material. And also on a different cell type or on a different tissue type, it might be completely different in a child. So everyone is unique, and it's about a sort of the balance of this extra material and how that works out in your child. Yeah, so in summary, so they can have a combination of like immune, like slightly lower cells, or a balance problem in the immune system. It's not caused by precocious aging. It's there from the very, very start, and we have to be aware of this. They can have increased, susceptibility to infections, problems with autoimmunity, like this thyroid that I mentioned, also inflammatory conditions, like this hidradenitis that I mentioned, or like malignancies, but some malignancies are actually less prevalent. The susceptibility is lifelong for most of the conditions, but not all. And so also adult doctors should be aware of these conditions. And everyone is unique, so it's a super wide spectrum in the Down syndrome community. So I would like to highlight, although I'm a pediatrician, I'm definitely, a pediatrician. I think it's good to highlight that we also, of course, have adult people with Down syndrome, and how are they actually followed up? So from an immunological phenotype, we have still lifelong infection risk, and actually they can still pass away even if they have less frequent infections. And we have to be aware that also this Alzheimer's is relevant. And also, if your parents are not around, who is going to look after you if you're 60 years old? So there are specific viral infections, as I mentioned, this COVID and this flu, especially in adults. I would recommend vaccinations. The vaccinations are good, the responses, but they can go down a little bit faster. And then we have these specific conditions in neurology, this Alzheimer, in dermatology, all kinds of like skin lesions, skin conditions that people actually need to know that they need to, and that they also can treat. The Down syndrome arthritis, which can need specific treatment, and then also these autoimmune conditions in the endocrine. I think it's quite challenging, the healthcare system. I would like to know if people have any experience with adult people with Down syndrome, because I really struggle as a pediatrician where to transition my children to. I'm trying to keep them sort of until they're 21, but there is an endpoint because I can't access any of the other children's sort of subspecialty care if I need something. So then you're really, really stuck because then you can transfer the child to transition to like an adult immunologist, but that's only immunology. I actually need someone who's more holistic. Who is that person in our healthcare system, I wonder? And I hope someone has a good answer for this because I haven't found that answer yet. And this worries me. Like, who advocates, who speaks up, who provides this holistic care? Why are the people with Down syndrome not included in these type of trials, even if they have more prevalence of some conditions? Then they should be in those trials, I think. And also, who is providing this targeted treatments? For instance, when we saw an increased mortality in the COVID pandemic in the adults, not in the children, did we have a plan in place or not really? And then I think for adult immunologists, I gave a talk to them last year and they said, why are you giving a talk to us? So that means I had to give a talk to them. I said, okay, you have to be aware of a lifelong issues that you can see, maybe, maybe not, of the immune system. You still have a lower threshold for antibiotics for chest infection. You will profit from vaccinations, also the seasonal ones. So give advice to your patients with Down. Try to prevent obesity and prevent isolation if you can. Include them in trials if you can, and ask otherwise the guardians if you feel that consenting is an issue. That doesn't mean you should not advocate or try to put them also in specific trials. And if possible, have a holistic approach in your healthcare. So yeah, this is basically the talk. Yeah, and I hope there are lots of questions. That I hope I
Excellent.
can answer. Yeah.
Brilliant. Well, that's super. Thank you so much, uh,
Yeah.
Micah. I think there's plenty of questions, lots of observations. You ask for people's experiences and they're sharing them. So I'm going to stop
Okay.
recording.
Yeah.
If you'd like to stop sharing the screen, then we can kind of
Yeah.
um,
Yeah, that's better. I will try to